Hello, good evening, everyone. First of all, I would like to welcome you all on behalf of the Diabetes Nepal team. We all know Diabetes Nepal is a non-profit public health organization established in 2010 to increase awareness of problems that can occur with diabetes in Nepal. Diabetes Nepal has been organizing regional as well as national-wise Indo-Nepal UK diabetes conferences each year. I am honored to say that we were able to conduct conferences despite the COVID-19 pandemic, and this is the third virtual meeting being held. Furthermore, this webinar has been approved by the Federation of the Royal College of Physicians of the United Kingdom for 2 CPD credits. Today, to make this conference more informative, we have 4 speakers, and they are Professor Satyanath Mukhopadhyay from Kolkata, India, Dr. Mahesh Singhdel from Kathmandu, Nepal, Professor Satyen Raj Bhandari from UK, and Professor Khin Sothan from Myanmar. Lastly, once again, I would like to welcome you all, and also would like to send my gratitude to USB on behalf of Diabetes Nepal for helping us to conduct this conference. From now onwards, I would like to hand over this conference to Dr. Tripti Sharma. Thank you very much. Namaste.
So, good evening, everyone. I'm Dr. Tripti Sharma from medical team of USV. So, I welcome you all today's conference. So, it's my honor to welcome the Professor Khin Sothan, the chairperson for today's meeting. So, Professor Khin Sothan is an endocrinologist working in a Grand Hantha International Hospital. She is the retired professor and head of Department of Endocrinology, University of Medicine, Yangon. She had initiated the doctoral course in endocrinology in University of Medicine, Yangon, and established Center of Excellence of Diabetes Care in Yangon General Hospital. She supervised master's students, internal medicine, and doctoral students in endocrinology. At present, she is the vice president of Myanmar Society of Endocrinology and Metabolism. So we welcome you, ma'am. With this, I will hand over to our chairperson, Professor Khin Sothan, to introduce the speaker of today's meeting. Over to you, ma'am.
Thank you, Dr. Tripti. Good evening, everybody. It's welcome to all of you to this important webinar. This is a third HExN Nepal diabetes webinar on nephropathy. As you all know, diabetes is put a great burden globally and each and every country. Despite our effort for the improved management, newer drugs on pipeline all the way long, still we are facing with the complications and the burden of this chronic disease. Among them, especially nephropathy, still for about 2 decades, we couldn't find any newer drug therapy to improve management of their diabetes, nephropathy or diabetic kidney disease, Dkd. But recent years, now we got the SGLT2 inhibitor and GLP-1 agonist. So after this, the management of the diabetes nephropathy being improved. Despite that, we have to do many things. We need to, so this important webinar, we got the 3 speakers. They will highlight about the management of the every step, every stage of the diabetes nephropathy till the transplant. So let me introduce the first speaker, Dr. Satynath Mukhopadhyay. He is a professor of the Department of Endocrinology and Metabolism, the IPG, MENR, Kolkata, India. He has more than 260 publications and got there are citations of more than 17,000. He is also the associate editor of the Diabetic Medicine UK and the member of the Governing Council Worldwide Cardio Diabetes, New York, USA. He is achievement of him is MMS Ahuja Memorial Oration, HExN 2014, PGI, and Chandigarh. He has received the award of the All India Diabetes Foundation Outstanding Achievement Award from the Mayo Clinic, Rochester, Minnesota in 2020. And he has been the tutor diploma for MSc Endocrinology, University of the South Wales, Cardiff, UK, and a visiting professor of the Manchester Royal Infirmary, Manchester, UK. So he has been the examiner of the PhD courses in many universities, including Visava Bharati University, Punjab University, including AIMS, as far as I know, University of Calcutta, University of Melbourne. So, Dr. Professor Satynath, it is your time. Please tell us about the burden of the nephropathy in diabetes. Let's listen to him.
Good evening, everybody. Hope I'm audible.
Yes.
Let me just share my screen. Visible?
Yes, sir.
Okay, so on to the presentation mode. Thank you, Professor Keen, for all the kind words. And I thank the organizers for having me for this important meeting. I have started my timer now for 35 minutes. So I think, okay, I have to make myself visible also. Yeah, there you go. Right. Okay, so I have been asked to cover the burden of nephropathy in diabetes and its management in the early stages, namely stages 1, 2, and 3. And then we have 2 other speakers to take us through the more advanced stages of DKD or diabetic kidney disease. So if you look very briefly at the burden and the pathophysiology of DKD, well, DKD is the leading cause of kidney failure worldwide and currently accounts for more than 50% of the patients enrolled for dialysis and transplant programs in the US. Unlike many other chronic complications of diabetes, the prevalence of DKD has failed to decline over the past 30 years. Hyperglycemia and hypertension are the prime etiological factors responsible, along with certain genetic predispositions and also dyslipidemia. Altered tubuloglomerular feedback, renal hypoxia, lipotoxicity, podocyte injury, inflammation, and mitochondrial dysfunction lead to progressive glomerular sclerosis and a decline in GFR. Recent studies have also incriminated abnormalities in autophagy and sodium hydrogen exchange mechanism contributing to the burden of DKD. Well, the exact contribution of each of these defects in the pathogenesis of DKD, particularly in the context of their relative contributions in DKD in type 1 and type 2 diabetes. SGLT2 inhibitors may reverse many of these pathophysiologic defects, as we shall see in a moment from now, in type 2 diabetes. As far as India is concerned, around 38% of CKD patients, they have diabetes. If you look at the bottom right pie over here, but unfortunately, my slice of the pie, which is restricted to stages 1, 2, and 3, as you can see, is rather limited. So early kidney disease, they contribute to fewer than 30% of all cases of DKD in India. Sadly, due to physician inertia to screen people with diabetes for chronic kidney disease, and at the same time, lack of awareness on part of the patients and the policymakers contribute to this dismal picture. So most patients at presentation have stage 4 or stage 5 kidney disease, where they miss the bus as far as the benefits of early interventions are concerned. Contrast this with the scenario in more advanced countries. Here I have put before you the data from ENHANCE between 1999 and 2002, which is ENHANCE 4 study, where you can see stage 4 and 5 kidney disease contribute to only 2% of all cases of DKD. So, and stages 1, 2, and 3 combined, they account for more than 35% of cases. So had I been practicing in the US of A, I would have a much larger slice of the pie to pay my attention to. So in the global burden of disease study, the data set of which we published recently in the Lancet, we observed that of the top 10 individual causes of death in India in 2016, deaths due to all non-communicable diseases increased, but what was alarming was the increase in death rates due to ischemic heart disease, diabetes, and chronic kidney disease. And if you take all of them together, then you are dealing with what is nowadays called the cardio-renal metabolic conglomerate or conundrum. So they all seem to increase in parallel, maybe part of a larger CRM syndrome or cardio-renal metabolic syndrome. A busy slide, but when we focus our attention on the disability adjusted life years or DALY related to the leading causes of non-communicable diseases, and we compare the positions of the leading causes back in 1990, we can see that there has been a steep jump in terms of the contribution of ischemic heart disease from 6th spot to the top spot. Chronic kidney disease has jumped from 30th spot to the 20th spot, and diabetes has seen a tremendous increase from 35th spot to the 13th spot. So again, the cardio-renal metabolic conglomerate, the individual components, they all seem to increase parallelly and kind of tend to compete with each other for the top spot. Then more recently, we published in the Lancet Global Health on the increasing burden of diabetes and so variations among the different states of India. So actually, we looked at the state-wise data, and looking at the author list, you can appreciate that all these states, large and small, of the country have been involved in this study. And again, a busy slide, but if you just look at the burden of chronic kidney disease as a cause for disability adjusted life years in the age group of 50 to 74 back in 1990, it was at the 10th spot, and then only year before last, it has gone up to the 8th spot. So from the 10th spot to the 8th spot, and again you can see this has paralleled the increase in fasting plasma glucose, body mass index, and systolic blood pressure. So they all seem to go together and contribute as a group to the burden of diabetes-related morbidity and mortality. Well, you are all familiar with how CKD in diabetes, or DKD, so to say, is classified. It's a combination of EGFR and albuminuria category. So albuminuria is classified as A1, 2, and 3, depending on urinary albumin excretion as measured in a spot sample. So the ACR less than 30 being A1, 30 to 300, A2, which is moderate albuminuria, and anything beyond 300 is severe albuminuria. So you can have A1, A2, A3 albuminuria category. And on the left-hand side, you can see how the staging of severity of DKD is done on the basis of EGFR, G1 being more than 90, and G5 or kidney failure being less than 15. Now, chronic kidney disease is often equated or being is used synonymously as kidney failure, but one has to understand the difference that kidney failure nowadays is defined as an EGFR less than 15 with any grade, any category of albuminuria, whereas all other stages of chronic kidney disease are known as a chronic renal dysfunction or kidney disease, and not kidney failure. So kidney failure actually indicates the end stage of chronic kidney disease. So is DKD a silent killer? The answer is yes. It's considered a cardiovascular disease risk equivalent. It's mostly a silent disease, as serum creatinine tends to rise only when more than 50% of the renal function is gone. Unfortunately, clinicians, and this data is from developed countries, screen only 20% of their diabetic patients for kidney disease. And of course, this is referring to a general practice and not to a specialist diabetes or endocrine practice. And the progression of CKD, the risk associated with hypoglycemia also worsens. So which is the best stage in the spectrum of CKD to intervene in order to get the greatest benefit? Well, possibly it's the stage of microalbuminuria with a normal creatinine clearance. The moment you have frank proteinuria, there is a sharp decline in EGFR, and very little can be done in terms of halting the progression or reversing the process, which he will hear from the subsequent speakers. So what are the risk factors that are important to look into in the management in patients with DKD? Well, topping the list is the ABC of good diabetes care. A standing for HbA1c, B for blood pressure, and C for LDL cholesterol. So the initial target should be to control all of these three factors, the A, B, C, and they should be kept within the recommended target HbA1c less than 7 for all patients, and less than 6.5 for particularly motivated early onset young patients. Blood pressure goal, I think, will be discussed in more detail by the next speakers because it depends on the CKD stage. By and large, a blood pressure less than 130/85 would be, I would be comfortable with. LDL cholesterol less than 100 for low risk patients, low in risk in terms of the risk for atherosclerotic cardiovascular disease, and high risk ASCVD patients should target for an LDL less than 70. Discontinuation of smoking is important. Dietary protein restrictions, well, I do not know what the speaker from Nepal will tell or the speaker from UK. In India, in general, very few people actually get or can afford the recommended daily protein allowance of 1 gram per kg. And so when they present with DKD, the protein restriction is already limited, I mean, naturally to 0.7 or 0.8 gram per kg per day. And further protein restriction may lead to body protein breakdown and may actually be counterproductive. So in India, actually, we take a detailed dietary history before recommending protein restrictions. And in most of the patients, we see that they are actually consuming less than 0.8 gram per kg per day of protein. So there is very little scope for protein restriction, at least in the early stages of the disease 1, 2, and 3, which is the focus of my presentation today. Avoidance of nephrotoxins is extremely important. Only yesterday evening, I came across a 59-year-old male who was referred to me for uncontrolled diabetes in association with CKD. On detailed history taking, I came to know that this person has been suffering from ankylosing spondylitis and has been using over-the-counter NSAID continuously, uninterrupted for last 2 years to ease his joint pains. And so this is a case of drug-induced nephropathy and not classic diabetic nephropathy. I think it's important to comment here that as far as DKD in type 2 diabetes is concerned, nearly 1/3 of patients may not have classic DKD. They have some other etiology for their chronic kidney disease, such as ANCA-positive vasculitis, focal segmental glomerular sclerosis, renal artery stenosis, hypertensive nephropathy, and so on. And there are certain important clinical pointers or clues by which one can suspect the presence of so-called non-diabetic kidney disease in a diabetic. And these are absence of retinopathy, active urinary sediment, heavy proteinuria, disproportionate hypertension, early and progressive loss of renal function, and so on. So these are the pointers that the patient may be also on imaging. If you see small kidneys or asymmetric kidneys, they all point towards a possible non-diabetic cause of renal disease in a diabetes subject. Of course, DKD and non-diabetic kidney disease can sometimes coexist in the same patient. And in classic diabetic nephropathy, there is a stage of nephromegaly initially. So by the time they make the clinical presentation, they still have normal renal size. So contracted kidneys and asymmetric kidneys on ultrasonography also point towards a non-diabetic cause. Use of radio contrast agents should be restricted in presence of DKD. If it's absolutely necessary to use them, then one should use a reduced dose proportionate with the degree of decline in eGFR, and where possible, use a non-ionic contrast agent. There are some recent studies showing blood uric acid correction having some favorable impact on the progression of CKD. Bicarbonate supplementation, I leave it to the subsequent speakers because they are more appropriate, I think, in the management of the more advanced stages of CKD. Well, coming to the use of oral agents, this is an old slide. What I would like you to note here is that glyclazide and linagliptin alone or in combination, they can be used safely in patients with DKD almost without regards to EGFR, and same is true with pioglitazone, although in a waterlogged patient or a patient having renal anemia or renal osteodystrophy or CKD, MBD, so to say, the risk of pioglitazone may be risky. Now, SGLT2 inhibition has come up as a novel intervention in CKD and has the potential to alter the natural history of the disease going by latest data. So this group of drugs, they have a number of potential direct and downstream effects which may result in beneficial effects on kidney function. And if you look here, that blocking the sodium glucose reabsorption at the proximal convoluted tubule results in an increased delivery of sodium to the macula densa at the distal tubule. Now, increased availability of sodium at the macula densa by way of a mechanism known as tubuloglomerular feedback causes vasoconstriction of the afferent arteriole and relieves the vasoconstriction in the efferent arteriole. So a combination of these two effects actually results in a fall in intraglomerular pressure, and which has a salutary effect in terms of progression of nephropathy or decline in EGFR, and also progression of albuminuria. And if you recall, the main mechanism of action of the ACE inhibitor ARBs or the RAS blockers are by dilating the efferent arteriole, and that's the mechanism by which they reduce intraglomerular pressure. So efferent arteriole is the site for actually SGLT2 inhibitors, and the RAS blockers may have a synergistic effect and lead to a significant fall in intraglomerular pressure, which is by and large beneficial, with the caveat that a sudden and sharp fall in intraglomerular pressure may lead to transient AKI-like situation, particularly in patients who are dehydrated and are on loop diuretics. So dapagliflozin I have taken up here as an example because we have large published data sets. So it showed renal disease progression, slowed renal disease progression in type 2 patients with relatively preserved baseline renal function, as was shown in the Declare-TIMI study. You can see a significantly reduced significant relative risk reduction. Similar data have also been published by Canvas and the EMPA-REG with respect to canagliflozin and empagliflozin. Then in the Declare-TIMI, dapagliflozin was also shown to improve outcomes in terms of the renal specific endpoints, i.e. decreased EGFR more than 40%, end-stage kidney disease or renal death. This renal benefit actually is demonstrated across the EGFR categories and also without regards to the presence of established cardiovascular disease or multiple risk factor for cardiovascular disease. Then dapagliflozin not only prevented the progression of CKD from the earlier stages to the more advanced stages, but it also resulted in regression of CKD from the more advanced albuminuria stages to earlier milder albuminuria categories. So to summarize the DAPA-CKD, there was significant relative risk reduction in terms of the primary composite renal endpoint, the primary composite endpoint, then the composite renal endpoint, and most importantly, significant 31% reduction in all-cause mortality, which is the hardest clinical endpoint in any randomized controlled trial. So accumulation of such encouraging data actually led the guideline makers to change their recommendations. And here this is the latest ADA-ASD guideline where I would like you to focus your attention here. If a presentation CKD predominates, then your agent of first choice is an SGLT2 inhibitor. American Society of Nephrology then follows suit, and they also tell us that if you have an urine ACR more than 300, but the eGFR is more than 30, again, your choice of agent should be an SGLT2 inhibitor. In the micro, if the urine ACR is in the microalbuminuria range and eGFR is more than 30, again, your choice is an SGLT2 inhibitor. No, the slide refuses to move. Oh, okay, so then the KDIGO treatment algorithm essentially tells us again the same thing. If the eGFR is more than 30, your choice is an SGLT2 inhibitor in combination with metformin. Now, switching gear from here and taking you through the data on hypertension control. Well, multiple studies have shown impressive relative risk reduction with RAS blockade in DKD. Of course, the on-target study demonstrated that there is no added benefit of combining an ACE inhibitor with an ARB. So there can be an initial decline in eGFR after initiation of RAS blockade. This is not considered a concern unless it exceeds 30%. So up to 30% decline in eGFR can be expected, and patients having such an initial decline enjoy long-term renal benefit. But if the eGFR loss exceeds 30%, then one should consider whether there is diuretic-induced hypovolemia. This is particularly common in the setting of concomitant use of loop diuretics. So maybe one should take the patient off loop diuretics. One should also look for renal artery stenosis or NSAID use. Any of these factors being present, one should discontinue RAS blockade. And if in their absence, one can safely continue RAS blockade. Of the non-pharmacological interventions, dietary sodium restriction remains important. Then one needs to moderate alcohol intake, perform regular exercise. Weight loss is beneficial if baseline BMI is more than 25, and it makes sense to reduce saturated fat intake in the diet while to restrict it to less than 7% of total fat intake. Is lowering uric acid beneficial? Well, I would just like you to focus your attention to the bottom line, which tells us that in type 2 diabetes, preserved kidney function, hyperuricemia seems to be an independent risk factor for the development of incident CKD. So maybe it makes sense to treat hyperuricemia in this setting. Now, of all the known pathophysiologic risk factors for CKD, you can see on the left-hand side that so many are actually beneficially impacted upon by SGLT2 inhibitors. They are hyperglycemia, hypertension, tubular glomerular feedback, podocyte loss and albuminuria, lipotoxicity, inflammation, hypoxia, and fibrosis. Impact of SGLT2 inhibitors on endothelial dysfunction, mitochondrial dysfunction, autophagy, tubular hypertrophy is yet to be established. Now, this is the last part of my talk. Well, so far I have told you that we do have the means at our disposal to at least address the ABC of good diabetes control and be able to prevent kidney disease. So we have the statins, we have the RAS blockers, and now we have the SGLT2 inhibitors also, plus minus the GLP-1 agonists and the gliptin. But are we in a position to implement these strategies of intensive control at a population level? Let me take you through the recent enhanced data published in NEJM. So if you look at glycemic control, while it improved from 1999 to 2002, then plateaued to 2010, beyond that, glycemic control deteriorated in the enhanced population. Same is the story with blood pressure control. There was initial improvement till 2010, and then it started deteriorating. Lipid control, after an initial improvement, it has plateaued. Now, if you look at the use of anti-hyperglycemic agent between the years 1999 and 2018, when this paper got published, you can appreciate that there has been a significant decline in the use of sulfonylureas and the glitazones. Insulin, after initial increase, saw a decline from 2014 onwards. So a void was created with the dwindling use of these medications. But is the void filled by the combined use of DPP-4 inhibitors, GLP-1 and SGLT2 inhibitors? No, they are not. You look at the rate at which the use of DPP-4 inhibitors, this line, and the bottom line, combined SGLT2 and GLP-1 have increased. So there is a tremendous scope here for increasing the use of SGLT2 inhibitors, GLP-1, and maybe DPP-4 inhibitors also to prevent the long-term complications. Now, in the interest of time, I cannot really discuss what are the reasons behind such decline in the use of the older oral anti-hyperglycemic agents and decline in the use of diuretics and calcium channel blockers. If questions come during the Q&A session, I would be happy to answer them. So this is the enhanced data between 2010 and 2018. You can see HbA1c less than 7, it has deteriorated. So 57% of the population enjoyed HbA1c less than 7 back in 2010. It's now down to 50.5. Blood pressure control has deteriorated. There has been slight improvement in HDL cholesterol. Now, in a similar time frame, Nagpal et al. From Delhi, India, they published their data and observation between 2006 and 2021, which they published in Diabetes Care 2006 and 2021 Diabetic Medicine respectively, wherein you see a similar trend. HbA1c control has deteriorated, lipid control has deteriorated, but an important difference is that blood pressure control in India has possibly improved between 2006 and today. So those of you who are interested in tackling the challenges of diabetes care at a population level, we have recently published this review, which discusses all this Indian study, the enhanced data, and so on. So coming to my concluding slide, the most effective means to reduce the growing burden of DKD is to achieve and maintain HbA1c, blood pressure, and LDL cholesterol within the recommended range, or the so-called ABC of good diabetes care. Targeting multiple defects simultaneously is needed to slow or prevent the onset and progression of diabetic kidney disease to kidney failure. Glyphosins, or the SGLT2 inhibitors, they favorably affect a number of pathophysiological processes underlying the pathogenesis of diabetic kidney disease. The renoprotective effects have been demonstrated in a number of large clinical trials involving not only dapagliflozin, which I discussed in detail, but also with the other glyphosins, namely canagliflozin, empagliflozin, and orthogliflozin. A combined use of SGLT2 and RAS inhibitors represents a promising novel approach which has the potential to prevent the development and progression of diabetic kidney disease. And finally, while we do have the necessary means to reduce the burden of DKD, at least in terms of controlling HbA1c, blood pressure, and LDL cholesterol. Implementation of this strategy at the population level remains a challenge, not only in developing countries like India and Nepal, but also in developing countries like US and so forth. With this, I end my presentation, and thank you for listening. Over to you. Over to you, Professor King.
Thank you, Professor Siddharth. You have beautifully elaborated the burden of the NCD, especially the diabetes, cardiovascular diseases, and the renal, these cardiorenal conglomerate. It has been up and getting the top position, a similar trend all over the world, and then you have highlight that the patients arrive to our medical care are still at a very late stage. So early detection, awareness, and screening of this DKD at the very early stage is very important for us clinicians, as well as to educate the people to come and seek our medical advice early. And you have beautifully described the mechanism of the kidney DKD and the benefit of the acidity inhibitors and the importance of managing the age-related hyperuricemia and the other risk factor to prevent our progression of the diabetic kidney disease. So at this point, I want to invite the next speaker. So I will allow the question to be asked at the end of the three speakers. Next speaker is a Professor Mahaj Segdal. He's he's now promoted to the professor in the Department of the Nephrology of the TU Teaching Hospital. He's also president of the Society of the Internal Medicine of the Nepal. He works as a consultant looking after renal failure patients and is responsible for the running postgrad course in the university as head of the Department of Internal Medicine. He has published more than 30 articles related to the kidney transplant, lupus disease, and many renal diseases, and in peer-reviewed journal and is the editor of the Journal of the Institute of the Medicine. Let's listen his talk describing the management on the later stages of the diabetic kidney disease. Professor Signal, it's your time, please.
Thank you for the nice introduction. Am I audible?
Yes, sir.
Okay.
Yes, sir.
Why the presentation mode is changing?
Sir, some error. Just this thing now. Stop presentation and again share, sir, please. Dr. Trupti,
Yes.
I think I just left some network issue.
Yeah, I think some network issue got disconnected. So dear viewers, the next speaker got disconnected due to some technical issues. We will going to start in couple of minutes. So please stay online.
तो अभी स्टे ट्यून का मैंने रख दिया है एम्बियंस के साथ लाइव का
Okay. Hello, Dr. Mahesh. So are you on mute?
So is that okay?
Yes, sir. I just give a cue and then going live, sir. Just a minute, sir. Yeah. Stand by, sir. Would you like go? We are live, sir.
Sorry for the technical hitch. Thank you for the nice introduction. I'm Mahesh Sigdal from Kathmandu, Nepal. And at the outset, I would like to thank Diabetes Nepal, HExN Nepal, and especially Professor Raj Bhandari and USP Nepal for organizing this beautiful and useful meeting this evening. I have no conflict of interest to declare. And in the next 35 minutes or so, we're going to be to discuss on management of chronic kidney disease in diabetes, especially the advanced stages. Since it's a broad topic, we'll be discussing the salient features only. So this is going to be the outline of the talk. The perspective of the talk has been well set by my previous speaker, why this topic is so relevant and important today. And we'll go through some common definitions we routinely use. We quickly run through the pathophysiology of diabetic nephropathy, when to refer a patient of diabetes and diabetic kidney disease to a nephrologist. Then we go through the management of advanced stages of diabetic kidney disease, and we'll conclude the talk. Coming to the definition of chronic kidney disease has been defined by KDIGO as abnormalities of kidney structure or function that has persisted for at least 3 months and that has implications for death. So the time frame of 3 months has been set to rule out or exclude the causes of acute kidney injury. And when we use the term chronic kidney disease, 3 things has to be included, as previously discussed by Professor Mukhopadhyay also. So we should mention the cause, what is the GFR category, and what is the proteinuria or albuminuria level. This chart or this diagram has been displayed before. So the importance of this diagram is that the prognosis of any stage of chronic kidney disease is largely determined not only by GFR, but also by proteinuria level. If we closely see this, a person having GFR more than 90 mils per minute has the same prognosis with severely increased proteinuria, has the same prognosis as a person having GFR of 35 mils per minute without proteinuria in urine. That means it is not only the GFR level, but also the proteinuria level and underlying cause of CKD that we should be looking at when we are seeing a patient of diabetes. And another term that we routinely use is diabetic nephropathy. And many times we interchange the terms diabetic nephropathy and diabetic kidney disease. Diabetic nephropathy refers to the classical glomerulopathy in diabetes, typically found in type 1 diabetes with retinopathy, and which has a serial progression that progresses from mild proteinuria or microalbuminuria, or that was usually called incipient nephropathy, then progresses to macroalbuminuria or severely elevated proteinuria, that was called overt nephropathy, and subsequently progresses to advanced stages of kidney failure. In contrast, diabetic kidney disease encompasses diabetic nephropathy and also other atypical causes of kidney involvement in diabetes. So it's a clinical syndrome that is characterized by persistent albuminuria and or declining glomerular filtration rate that is usually associated with raised blood pressure and increased cardiovascular morbidity and mortality. It incorporates the classical diabetic nephropathy along with non-classical features, as I just said, and tubulointerstitial vascular lesions. While labeling as diabetic nephropathy, or when we see a patient of diabetes having proteinuria in urine, we should make sure that that is repeated at least once in 3 to 6 months to make sure that we exclude the transient or physiological causes of proteinuria in urine. That includes exercise, infections, heart failure, severe hyperglycemia, etc. Let's quickly run through the pathogenesis of diabetic nephropathy. The primary underlying force that drives the diabetic nephropathy is metabolic factor or hyperglycemia, along with hemodynamic factors that then subsequently incite the growth factors and inflammatory and profibrotic cascades that eventually leads to cellular proliferation, mesangial expansion, thickening of the glomerular basement membrane, and the endpoint is sclerosis or advanced diabetic glomerular sclerosis. So if we look at the pathology, the Consensus Conference on Classification of Diabetic Nephropathy has classified diabetic nephropathy into 4 stages with serial progression, with the first stage that is essentially normal in light microscopy and characterized by thickening of the glomerular basement membrane as evidenced in electron microscopy. Then the stage 2, that is then the class 2, that is characterized by mesangial expansion, which is subdivided into class 2A and 2B. Then the stage 3, the class 3, that is characterized by the classical nodules or KW lesions in the biopsy, and the advanced class 4, that is characterized by global glomerular sclerosis involving more than 50% of the glomeruli. Along with this classification of the glomerulopathy, a biopsy report should also, this is the diagram, this is showing thickening of the basement membrane, this is showing mesangial expansion, this is showing nodules, and this is showing advanced diabetic glomerular sclerosis or class 4 diabetic nephropathy. And along with the biopsy report should also include the interstitial fibrosis and tubular atrophy, that is whether it involves less than 25% or more than 25%. Then also the vascular lesions in the form of arteriolar hyalinosis, whether it involves the afferent or efferent arterioles. How does this pathological classification and classes correlate with clinical presentation? The class 1, in the clinical presentation of diabetic nephropathy at the point of diagnosis or early in the course, there is glomerular hypertrophy that is characterized by increased GFR, at least up to 20% increase in GFR. Then the GFR comes down to normal, that is a state when we get thickening of the glomerular basement membrane. Then a stage of mesangial expansion when there is microalbuminuria, then a stage of overt nephropathy or macroalbuminuria when there is progression and presence of Kimmel-Stell-Wilson lesions, nodules in the biopsy, and then the advanced stage that is like class 4 in the biopsy and the stage 5 or advanced renal disease. A good thing to know is not every patient with diabetes has a progressive course, and we now have a range of armamentarium or management strategies that we can use to retard the progression of diabetic kidney disease. The albuminuria progression is not inevitable, as referred to and beautifully explained by previous speaker. Also, the proteinuria can be retarded, like increased proteinuria can be brought down to normal level with appropriate therapeutic intervention. Let's look at this line diagram. Early in the 80s, the annual rate of decline in GFR in a patient with diabetes used to be around 10 mils per year. So 10 mils per minute annual rate of decline. And in the early 90s, there were some medicines like ACE inhibitors, then subsequently angiotensin receptor blockers came into practice. So that retarded the progression, annual fall in GFR to around 5 mils per minute. And with now availability of new drugs and strategies to tackle diabetic kidney disease, like SGLT2 inhibitors, the annual rate of decline in kidney function, or GFR, has come down to around 2. But in a normal person above 40 to 50 years of age, the expected decline in GFR is around 1 mil per minute per year. So we have still not hit the target. So we aim to retard the progression or decline in GFR to that of a normal non-diabetic person. So now coming to the topic profile, the first issue is when should an endocrinologist refer a patient of diabetes with kidney involvement to a nephrologist. So the first instance when the patient has to be referred is when the diagnosis is suspicious, when the diagnosis is not sure. We'll discuss about this in the later slides. And second is when the patient has advanced stage of kidney disease, or when the GFR is less than 30 mils per minute, and when there is resistant hypertension or difficult to control hypertension, and when there are a lot of complications of chronic kidney disease, which could be in the form of hyperkalemia, anemia, CKD, MBD, fluid overload, etc. When I get a patient of diabetes with kidney involvement, what do I do as a nephrologist? So how do I manage a patient of chronic kidney disease in diabetes?
Yeah, I think again the network issue has the speaker end. Yeah.
It looks like there is a power cut in his flat.
Mhm.
Yes, sir. Stand by.
Yes, sorry for the power cut.
No issues.
There was a power cut. I'm extremely sorry for the hitch in the presentation. So, coming to the management of diabetes, chronic kidney disease in diabetes. So from now onward, most of the points I'm discussing would be based on the KDIGO guideline. So the management of chronic kidney disease in diabetes focuses the following areas. First, the management of diabetes or hyperglycemia. Then the next question is it diabetic nephropathy or is it diabetic kidney disease or not? Are there acute reversible factors or not? Drug dose management and radiocontrast exposure. And the issue of management of associated conditions, the issue of management of other complications of diabetes, especially the cardiovascular disease, and addressing the progression factors in chronic kidney disease, management of complications arising due to loss of renal function, infection prevention strategies, promoting or maintaining nutrition and diet, and planning and preparation for renal replacement therapy and initiating renal replacement therapy. Let's see them. There's such a wide range of management strategies, but as is true for the management of diabetes or any chronic kidney disease, the management of any chronic illness, the management of chronic kidney disease also starts with self-management education program. And one of the most useful one is self-monitoring by the patient and seek the protocols for drug discontinuation. That is so important while managing early stages of diabetic nephropathy as well as advanced stages of diabetic nephropathy, such as like when the patient develops diarrhea, which is so common in our parts of the world, they could be educated to stop drugs like metformin or like to stop drugs like SE inhibitor or ARBs. This pyramid beautifully describes the comprehensive management strategies for diabetes, and that is so true for management of diabetic kidney disease also. Generally, almost all of the patients, in almost all of the patients, the management should focus on glycemic management, blood pressure control, management of dyslipidemia, smoking cessation, addressing the nutritional factors, addressing the exercise needs. Then most of the patients will be benefited by use of SGLT2 inhibitors and RAS blockade, and some of the selected group of patients will require antiplatelet therapies also. Coming to the management of diabetes or hyperglycemia, when this management of hyperglycemia is important in the advanced stages of diabetic nephropathy, as is true in the management of early stages of diabetic kidney disease also. When we manage blood sugar in a diabetic patient with kidney disease, the important consideration are we should be focusing on efficacy and safety of the glucose lowering therapies. This is a whole list of glucose lowering therapies we have. But when we look at some of the limitations of these drugs are this metformin should be discontinued, generally discontinued when the GFR goes to below less than 30 mils per minute. Long-acting sulfonylureas, because of the risk of prolonged hypoglycemia, should generally be avoided, as previously discussed by the Professor Mukhopadhyay also. These glitazones, especially the pioglitazone, has fluid retaining effect and could probably aggravate the anemia of chronic kidney disease also. These DPP-4 inhibitors, especially liraglutide, could be used up to GFR of 15 mils per minute, but this is as yet not available widely and not available in Nepal. These DPP-4 inhibitors are safe in chronic kidney disease. There is low risk of hypoglycemia, and especially the linagliptin and TNLgliptin do not require dose reduction in patients with advanced stages of kidney disease. Also, this GLP-1 agonist, they could be used up to GFR of 15 mils per minute. And about the new miracle drug, SGLT2 inhibitors, they generally should be avoided. Should not be started at GFR level less than 30 mils per minute, but if they have been started and are well tolerated up to GFR of 25, they could be continued. And about the insulin, the risk of like hypoglycemia should be considered. And when we are managing hyperglycemia in diabetic kidney disease, we should also obviously we should look beyond sugar control, like the benefits endpoint reduction provided by SGLT2 inhibitors or GLP-1 receptor agonists. And about the use of insulin, as the kidney disease advances, the insulin resistance increases, but as the patient gradually enters into dialysis or stage 4 kidney disease, the half-life of insulin increases because almost 50% of the externally given insulin is metabolized by kidney. So whatever insulin we give will remain there in the circulation, will be effective for a long time. So the risk of hypoglycemia increases. Another important issue in managing hyperglycemia in chronic kidney disease patients in advanced stages is the monitoring of the blood sugar. So far, the validated and widely recommended monitoring tool is use of HbA1c. However, in advanced stages of diabetic kidney disease and in a patient on dialysis, this could be erroneous and erroneously low because of the anemia, because of use of erythropoietin, because of certain RBC half-life, because of carbamylation issues. And on top, this A1C test also may not be reliable in every laboratory that is around us. And when we come to the dialysis patients, the issue of hypoglycemia during dialysis is pretty common. So the recommendation to reduce the dose of insulin on the day of dialysis, in the morning of dialysis, is very pertinent. So for the early stages of diabetic nephropathy, as discussed earlier, intensive sugar control could be beneficial, but as the diabetic kidney disease advances into stage 4, the tighter blood sugar control is not recommended. Just this is a beautiful slide that depicts like when we aim for sugar control, when we aim for sugar control, we have to look at the stage of chronic kidney disease, whether there are obvious macrovascular complications or not, what are the comorbidities, what is the life expectancy of the patient, is there autonomic dysfunction so that have hypoglycemic awareness problem or not, what is the level of care available at home, what is the propensity of treatment to cause hypoglycemia, and looking at this, in earlier stages, in a relatively young patient without much comorbidities, we aim for tighter blood sugar control. But in advanced stage of CKD, in an elderly patient with a lot of comorbidities, the A1C target should be really lax one. And as discussed earlier, this A1C itself could be pretty low, but still the patients could have like hyperglycemia because A1C could be less. Due to this immature red cells in the circulation in advanced CKD stages on erythropoietin. These slides and these issues of the large benefits of glyphosins in different renal endpoints has been discussed beautifully by the previous speaker, and similarly about the DP4 inhibitors and GLP-1 receptor agonists has been discussed earlier. Then another important issue that has been highlighted by Professor Satynath also, but since it is so important, it merits repetition here. And another important issue our nephrologist or endocrinologist saying diabetic kidney disease should focus on is it truly diabetic nephropathy? Is it truly diabetic kidney disease or not? Since the diabetic nephropathy or diabetic kidney disease is generally a presumptive diagnosis, because we make a diagnosis of diabetic nephropathy based on circumstantial evidence. So we check non-diabetic kidney disease when there is evidence of inflammatory kidney disease manifested by presence of hematuria, persistent hematuria, presence of dysmorphic red cells in urine, presence of red cell cast, or even like when there is persistent sterile pyuria. Then when there is obvious evidence of systemic disease like lupus, obvious evidence of systemic disease like ANCA vasculitis, when the proteinuria is very, very high, or like in the timeline of when you have a patient who is in your follow-up, there is sudden increase in proteinuria, like if the proteinuria was around 300 milligram in 24 hours in the last last year, if the proteinuria has gone to nephrotic range, in this year, probably we should look for alternative cause of proteinuria. And another important thing is, if the GFR is declining very rapidly, it could be non-diabetic kidney disease. This rapid decline in GFR in case of, is defined as annual rate of decline in GFR by more than 5 mils per minute. And absence of retinopathy, though we understand that this retinopathy nephropathy correlation is very, very strong in case of type 1 diabetes and not so equally strong in type 2 diabetes, but still absence of retinopathy should prompt us to look out for causes of non-diabetic kidney disease. And another important thing in management of chronic kidney disease, any chronic kidney disease is looking for cause of AKI. So is there any cause of AKI or whatever creatinine I'm seeing is primarily due to chronic kidney disease only? So you have to rule out pre-renal cause, you have to rule out obstruction, you have to rule out vasculitis or infection or accelerated hypertension. Because this ruling out AKI means taking care of the reversible factors in the progression of kidney disease. And this is also so important because all this, this chronic kidney disease is one of the most important cause of AKI, and repeated or recurrent episodes of AKI is a risk factor for faster progression of chronic kidney disease. Then about the management of drug doses and radiocontrast exposure, obviously I would only say, like, whenever you are not very sure about the drug dosing in chronic kidney disease, just refer to the references. And so many of the times we as nephrologists, when we look at the treatment card, our job is to stop or reduce or adjust the dose of various medicines. And about the radio contrast, it has been discussed before also, like avoiding to the extent possible using non-ionic or low osmolar agents and adequately hydrating the patient in the peri-procedure period and subsequently monitoring the patient is so important, because like avoiding radio contrast altogether may not be possible because it depends on the priority of the investigation. If the patient is going for coronary angioplasty for acute myocardial infarction, it has to be done. If the patient has to undergo radio contrast exposure for suspected malignancy, it has to be done, but then with optimized care. Then coming to the management of associated conditions, like the associated conditions are hypertension, dyslipidemia, obesity, smoking, and hyperuricemia. We'll discuss some of these later also. About smoking, though there is no solid evidence that quitting smoking will stop progression of kidney disease. However, it has so many cardiovascular advantages that quitting smoking is should be strongly recommended in every patient with diabetic kidney disease. Then similarly about the issue of hyperuricemia, it has been discussed before, let me not dwell into it again. About obesity, in the earlier stages of chronic kidney disease, like avoiding obesity is an option, but as the patient enters advanced stages of CKD, only the well-built patient or relatively obese patients do better in dialysis. So just only like recommending BMI to less than 40 would be recommended. And about the dyslipidemia, it has been discussed. And so the managing the other complications of diabetes, like especially cardiovascular disease. So these patients of diabetic kidney disease, not all patients of diabetic kidney disease reach end-stage kidney disease because they die in the course, because they are elderly and they succumb to infection, and because they are elderly and they succumb to cardiovascular diseases before they reach ESRD. That's the reason why not every patient of diabetic kidney disease reaches ESRD. And so the burden of cardiovascular disease in diabetic kidney disease is very high because of all these traditional risk factors and also the non-traditional risk factors in the form of anemia, volume overload, CKD, MBD, like calcium phosphate abnormality, use of erythropoietin, effects of dialysis, and frequent high volume ultrafiltration, because of the role of inflammatory status, and maybe because of use of iron therapy, which is also said to be toxic to heart. Then coming to how do we address the progression factors in kidney disease or diabetic kidney disease. Some of this has been addressed before also. These are all the progression factors, and out of these, most important would be again management of hyperglycemia, though tighter glycemic control in advanced stages of CKD is not recommended. Then management of hypertension, as taking care of the proteinuria issue, asking the patient to quit smoking, and taking care of the protein intake and other things, and decreasing the intraglomerular pressure or glomerular hypertension with the use of agents like RAS blocker, SGLT2 inhibitors, or mineralocorticoid receptor antagonists. Coming to the hypertension issue, so the management of when we manage hypertension in a diabetic kidney disease patient, we should consider a few things. If diabetic kidney disease is non-proteinuric, your target may be 140/90 is appropriate. If there is significant proteinuria, you aim for a tighter blood pressure control, 130/80, or if it is more than 1 gram in the 24 hours, maybe 125/75, or up to a level the patient tolerates with the maximum use of drugs like ACE inhibitor or angiotensin receptor blockers, maximum tolerated dose of the drugs like ACE inhibitor or angiotensin receptor blockers. So that is about hypertension. But if the patient is on dialysis, probably you should be happy with pre-dialysis blood pressure of around 150/90 and post-dialysis blood pressure of 130/80. And another is important use of mineralocorticoid receptor antagonists. Though the conventional mineralocorticoid receptor antagonists that are available are spironolactone and eplerenone, though they are found to retard proteinuria, they were not very useful in reducing the hard endpoints. However, the newly available, like the new one, non-steroidal mineralocorticoid receptor antagonist finerenone, has been found to reduce renal endpoints, and probably it will change the landscape in the use of like retarding proteinuria and retarding progression of chronic kidney disease in diabetes, especially since we now have other armamentarium to take care of hyperkalemia with the use of ACE inhibitor and mineralocorticoid receptor antagonist, because the limiting factor in the use of ACE inhibitor or angiotensin receptor blockers in chronic kidney disease is rise in creatinine or hyperkalemia. So as previously alluded to, rise in creatinine or fall in GFR up to 30% should be acceptable. That will eventually in fact benefit the patient. And if there is more than that, probably we should take care of other factors and consider stopping and reducing the dose. And hyperkalemia, like just because a patient has 5.7 potassium, you should not be rushing to stop the use of ACE inhibitor ARBs. Another important issue is whether combined ACE inhibitor ARB would be beneficial. As of now, probably it will not be, but then the OnTarget trial was flooded with use of dual blockade in relatively high-risk patient with lesser proteinuria. If a patient has relatively preserved GFR in the early stages of CKD with significant proteinuria, no hyperkalemia, this could be an option, but right now it cannot be recommended. So the nephrologists around the world are using supratherapeutic level of dose of ACE inhibitor angiotensin receptor blockers, provided there is acceptable hyperkalemia. And another is SGLT2 inhibitor to reduce intraglomerular hypertension, to reduce proteinuria, to reduce progression of kidney disease, and this has been discussed. So this again shows the beautiful effect of mineralocorticoid receptor blockade. Apart from controlling blood pressure, it has anti-inflammatory effect. It affects the oxidative stress favorably, and it reduces the maladaptive response. So it has cardiac benefit also. If we can use it, it would be beautiful, but it would not be very rational to use it in advanced stages of CKD. So these are some of the trials and molecules, which are some of the molecules that have been found to be useful in retarding the progression of chronic kidney disease. And these are some of the molecules that were tried in the use of diabetic kidney disease in the early stages, but then were not found to be useful. Now coming to another aspect of management of the diabetic kidney disease, another aspect would be management of the complications arising due to loss of renal functions like anemia, CKD, MBD, acidosis, and others. When we consider management of anemia, the most important thing we should consider is the diagnosis of anemia of chronic kidney disease is again a diagnosis of exclusion. So whenever we see anemia, we should try to find out the cause of anemia in itself, because CKD may not be the cause. The patient could be having all of the possible causes of anemia like any other person not having CKD. Second important point is we do not aim for normalization of hemoglobin. There have been a couple of studies like CREATE, TREAT, QUARE trials, which concluded that like targeting normalization of hemoglobin is not useful and is counterproductive in the form of increased strokes and access thrombosis. So no, we do not aim for normalization of hemoglobin. One important thing.
Could you finish in a few minutes, please?
Sure, thank you. And third important thing is we should start the management with substrate supplementation like iron and vitamin deficiency. Then the use of erythropoietin and the newly available HEF stabilizers judiciously. Then coming to the management of CKD, MBD, not every patient of chronic kidney disease, even in stage 4 or 5, needs calcium or active vitamin D3 supplementation. So we have to look at calcium, phosphorus, PTS, vitamin D level, and then play with these calcium, non-calcium phosphate binders, active vitamin D3, cinec acid, etc. And coming to the issue of bone mineral density or DEXA scan, this is not commonly used in CKD because it is the interpretation is difficult, and these bisphosphonates are generally contraindicated in patients with GFR less than 30. And coming to metabolic acidosis, bicarb is supplemented to maintain bicarb target more than 22. And for fluid overload, the most important counseling is limitation of sodium intake to less than 2 grams per day. And for uremic symptoms, probably initiate with renal replacement therapy. Another important issue is infection prevention, which is the most important during vaccination. All the patients of advanced stages of CKD should get pneumococcal and influenza, annual influenza vaccine, and they should be vaccinated against hepatitis B with higher dose rapid sequence vaccination with 6 months booster and followed by antibody titer testing. And all the vaccines as appropriate they should receive because they are at high risk of infection. About the lifestyle things, they should be encouraged for exercise, maintaining optimal body weight. Dietary supplements are generally not recommended. And about the protein diet, generally like the recommended is around 0.8 gram per kg, but if, you should take into account the protein intake of the person. So until unless patient enters dialysis, it is around 0.8 gram per kg per day. And if the patient is entering dialysis, around 1.2 gram per kg per day would be recommended. And we should take care of the potassium also, and sometimes leaching of the vegetables would be useful. And now about the planning and preparation for renal replacement therapy. When the patient is advancing into a renal failure, we have 3 options for renal replacement therapy: transplantation, dialysis, and supportive care. We should understand that not every patient in stage 5 CKD or advanced kidney failure requires dialysis or transplantation. So our aim should be living with quality and dying with dignity. So discussing with the patient relatives whether they want to go for dialysis options or not, that is very important. And if possible, we should aim for preemptive kidney transplantation. And counsel for donor selection appropriately. About the dialysis options, whether peritoneal hemodialysis depends on the patient characteristics and the choice of the patient, convenience of the patient. And we should focus on advanced vascular access planning, like whether fistula is going to be mature or not, whether if it is a very elderly patient or starting dialysis, probably toral cuff catheter should be okay. Then this vascular access planning should be at least 6 months prior to anticipated time to dialysis. Then about the PD catheter placement, around 3 weeks to 6 weeks prior to anticipated time to dialysis. Then if the patient has to move to CTs for replacement, that has to be discussed. Then about the initiating RRT, the only thing is we don't look at any lab parameter and decide whether the patient requires dialysis or not. The ideal study has clearly said that we should look at the patient clinically and then labs and decide whether the patient should be started on dialysis around GFR of 7 to 10. If there are other clinical indications, dialysis has to be started. So to conclude, so chronic kidney disease is a pandemic. Diabetes is the top cause of chronic kidney disease and end-stage kidney disease. Multidisciplinary comprehensive care is the standard of care today. Blood pressure and blood sugar targets need to be tailor-made. Timely referral to a nephrologist would ultimately improve the outcome of the patient. Look in any patient with diabetic kidney disease, look for non-diabetic cause of renal disease always. Look for acute kidney injury in any patient with chronic kidney disease. Advanced care plans ultimately pays off. Preemptive kidney transplant is your goal, and starting of renal replacement therapy should be timely as suggested and evidence given by IDEAL trial. Thank you. Once again, sorry for the technical glitch and power cutoff. Thank you. I'll be happy to answer questions at the end of other speaker.
Thank you, Professor Mahaj. You have extensively elaborated the management of the advanced stages of the diabetic kidney disease. So because we have overshot the time, so I'll invite the third speaker, Professor Satyant Raj. Is a professor. He's a consultant diabetologist in Lancashire Teaching Hospital and has been active in education and research in the field of the diabetes. He has published more than 100 papers in peer-reviewed journals, also a clinical champion appointed by the Diabetes UK National Charity for People with Diabetes. He is a General Secretary of the Health HA in Nepal, which is involved in clinical and educational support to Nepal. So let's, Professor Satyant Rajbandari, it is your time. Let's listen his presentation.
Thank you. Now, can you see my screen?
So we can see, but you have to
Yes.
make it in slideshow. Now it's fine.
Also, okay, great. You can start. Thank you very much. Today, I'm talking about transplant and diabetes. Transplant and diabetes is a two-sided coin because diabetes could lead to transplant and transplant could lead to diabetes. I think I'm just showing you a famous coin for 100 years of insulin minted in Canada for $2. So that's the transplant in diabetes, two sides. Now, the most common transplant in diabetes is kidney transplant, which the symposium is focused on. Kidney transplant could be live donor or deceased donor. Additionally, in type 1 diabetes, there is scope for pancreas transplant, which could be simultaneous pancreas kidney transplant or pancreas after kidneys. And also there's eyelid transplant, which is going gradually. End-stage renal disease, I don't have to talk too much because previous speakers have done. Just to briefly, 40% of patients undergoing dialysis have diabetes. But again, this percentage varies quite a lot in other countries. I think in Nepal and India, it may be much higher than this. And any patients who have diabetes for 25 years, there's 4.3% of risk of having end-stage renal disease. So effectively, 5%, that is almost 1 in 25 people who have diabetes for 25 years will have end-stage renal disease. Diabetes increases risk of end-stage renal disease by 8-fold. But however, end-stage renal disease, there are significant ethnic differences. So data varies from one country to other country, and also one type of population to other population. Now, all patients with end-stage renal disease should be considered for transplant. But again, the criteria in different countries depends upon the supply. And nowadays, there are a lot of thoughts going about preemptive transplant. That is transplant before the need of dialysis, because that has shown to have better outcome. Now, few contraindications to transplant. One is metastatic cancer, ongoing or recurring infections, and that becomes a problem for me because I do deal with diabetic foot ulcer. So people with foot ulcer are really put back on the transplant list unless it's cured. Serious cardiac or peripheral vascular disease, hepatic insufficiency, unless you're go for liver kidney transplant together, reduced life expectancy or advanced age, and medical non-compliance when we don't give transplant. And I think in the private healthcare system, like in Nepal and India, financial constraint will be a factor for transplant, although it's not a contraindication. Now, I just want to share you with a story of a leg for kidney, mainly because I do both diabetic foot ulcer clinic too, along with transplant diabetes clinic. So I had a patient, young type 1 diabetes for about 20 years. He had chronic diabetic foot ulcers and CKD4. He had calcaneal osteomyelitis, and it healed but recurred again. And he was otherwise fit for rehab. And then when he needed transplant, when he became CKD5, his transplant was withheld because he had chronic infection. It would not clear. We had a long chat. Then we decided that let's go for elective below-knee amputation, although there was a chance that it would heal. And he agreed to it. The below-knee amputation healed, and he was appropriately rehabilitated. And when he got his transplant opportunities, he received donor kidney and a pancreas together. And effectively, the patient was very happy. I always joke with him in the clinic that he swapped his leg for a kidney and pancreas. So that's how the story is. So we have not only one, 2 or 3 similar cases. Now, there are a lot of legal issues with transplant. In many countries, and including Nepal, it's close relations who can give transplant. Although in some other places, there are altruistic donors, non-related donors are there. Then there's issue about donation, donation in brainstem death or circulatory death, how to define death. There are some legal issues that. In the UK, recently, they have adopted a law where there's a universal consent for donation. So anybody who dies, they have given consent for donation. It's accepted that way, unless he's opt out, rather than opt in, it's opt out. With that, they have increased the supply of the organs. So it has just changed recently. Now, along with that, there are a lot of illegal organ trade going on. And there have been few issues in China about death row prisoners being a donor, whether they will be allowed or not. And there's a lot of hue and cry. And as a result, there are a lot of stories in the newspaper, doctors, nurses jailed for organ trafficking. And in Nepal, there was some paper in Lancet, organ trafficking after earthquake. So there's a lot of legal issues, and sometimes it's something funny legal issue also that, like in the UK, 1 or 2 cases where the ambulance driver has been charged for speeding when they were carrying a transplant organ. Now, kidney transplant, which is most common, we have the living donor gives good results with minimal ischemia. For brain dead donor, organs should be harvested within few minutes of stopping the life support. And transplant after more than 12 hours of cold ischemia has high failure rate. 1 year graft survival for transplant is about 95%, and 5 years is 90%. So that's quite good survival rate. And generally, the transplant is usually done in the pelvis area, lower abdomen, right iliac fossa or left iliac fossa area. And the ureter is connected to urinary bladder. Pancreas transplant is usually done in, it's always done in type 1 diabetes with or after kidney transplant. Generally, pancreas transplant alone is not done. It's advocated in patients with severe hyperglycemia on awareness. But nowadays, in our area, if there is a scope of having a pancreas available along with kidney, we give them straight away. Donor's pancreas survival is also pretty good, about 90% in 1 year and 80% in 5 years. But pancreas transplant is always a problem how to do with the pancreatic duct, because they do secrete a lot of corrosive enzymes. So either it can be drained into urinary bladder with ileal conduit or directly to GI tract. Then eyelid transplant. It is increasingly used in the UK and in the USA. It is used in type 1 diabetes, severe hyper-awareness. But one got to remember that for the eyelid transplant, you need at least 2 pancreas from brain dead donors. Pancreas can only be given by dead donors, not by live donors. And even though you give eyelid transplant, you still need immunosuppressive therapy. Otherwise, those eyelid will be rejected. And when you transplant, eyelid transplant is much easier for the recipient because it's injected in the portal vein under imaging guidance. And about 60% do not need insulin at 12 months. So that's a fairly good success rate, but not as good as that of pancreas transplant. So if you see in the picture, the eyelid from pancreas, they undergo collagen digestion in a Ricardo chamber, and the exocrine pancreas are removed, and the purified islets are injected into the portal in the portal vein, and they get lost within the branch of portal vein. So your islet cells remains in the liver, not to the pancreas. Liver transplant, mostly for cirrhosis, but also for hepatitis, metabolic condition, and paracetamol poisoning. You can have both cadaveric or live donor. And there is a high risk of hyperglycemia after liver transplant. Now, because there are many people with liver failure, in the UK, they have got strict assessment process using transplant benefit score. The survival is about 75% after 5 years. In the liver transplant, the donor takes a portion of the liver and put the recipient. Heart transplant is mainly for heart failure due to ischemic heart disease, cardiomyopathy, and congenital heart disease. Those patients should be fit otherwise. And it's carried out by only limited specialist center in the UK. It has to be cadaveric or brain dead donor. And it has got pretty good survival rate of 75% after 5 years. The heart transplant, you have to transplant whole heart, including and connect to the vena cava and aorta. Lung transplant is usually for COPD, cystic fibrosis, pulmonary hypertension, or idiopathic pulmonary fibrosis. We can have single lung transplant or double or with heart-lung transplant together. Sometimes they also tend to do domino transplant when they give heart-lung transplant to a patient and the patient's heart is transplanted to someone else. It's usually done as a cadaveric, but two living donors can give for one recipient. And always the problem is due to supply, and 50% survival rate after 5 years. And this is a picture of lung transplant, where you give the lungs to the same position where it is. You can give single or double. Now, the other transplant we commonly use is stem cell and bone marrow transplant. And it's usually for aplastic anemia, leukemia, lymphoma, myeloma, congenital hemolytic anemia, or combined immunodeficiency. Bone marrow is used from a donor, and recipients should be given chemo or radiotherapy beforehand as a conditioning treatment. Otherwise, they will have rejection, and there is a high risk of infection with that. So they have to stay in the bubble, and that's always a big problem. And there's always a concern about graft versus host disease, where the donated marrow acts on the host. So bone marrow is extracted from the iliac crest usually, and then is infused into peripheral veins. So it's easier for the recipient, but again, you have to go through a lot of conditioning things. Now, if you see transplant-wise, you can transplant the whole host of things like cornea, heart valve, skin, bone, hand, face, uterus, small intestine, and even in some cases, whole body. Those people who are paralyzed, they take the head out and transplant to the other body. So that's been attempted. So almost everything can be transplanted. The only worry or one problem is you need to get the donors. And usually donors are for these things are people who die in accident, like our Prime Minister of the UK, who is driving without helmet, cycling without helmet on the rear line. So he's at risk of dying young, and these are the organs where we get. Now, before transplant, they go risk assessment for transplant. The risks are like if they are more than 50 days, more risk, male, people with diabetes, CVA, ischemic heart disease, peripheral vascular disease, smoker, if you have poor blood pressure control, if albumin is less than 35, underlying malignancy, underlying infection, these are all risks they will assess. The lower the risks they are, the higher their priority in the transplant list. Even if you have risk, you'll still be in transplant list, but these are the assessment they will do in each cases before they are transplanted. Now, to register for transplant, they'll have ABO and RS group type. Then they'll go for different titers, CMV, hepatitis B, hepatitis C, HIV, and varicella zoster status. Because if they're active viral infection, they tend not to give a transplant. Then they have to undergo HLA typing, and they also go for malignancy screening. And they also have to go for heart disease screening. They have ECG, echo, and if needed, thallium scanning of heart or treadmill test or angiogram if needed. Once they are accepted for a cadaveric transplant, they are given a pager so that they are summoned anytime they have to come straight away to the hospital, and they are instructed to have an overnight bag packed all the time so that they can come at a short notice. So their life is always at a hold. They can't go on a holiday, stay back. Now, for the eligible donor recipient match, they match ABO blood group, then they go HLA tissue typing match, they have cross-matching, then panel reactive antibody test, and serology screening. That's most important for stem cell transplant. Now, with a transplant, rejection is the main concern. Like anything in their life, from love to marriage to everything, rejection is the main concern in transplant. The clinical stages of rejections are hyperacute within minutes or hours, acute rejection within first 6 months, or chronic rejection after repeated episodes of acute rejection. So rejection is the biggest problem in transplant. And we have immunosuppressants to prevent rejection. The immunosuppressive drugs are given in 2 phases: initial induction phase, which involves high dose, and the maintenance phase using drug in the long term at a lower dose. And in between, when this acute rejection in between happens, you have to give higher dose. So the most commonly used immunosuppressants are calcineurin inhibitors like Tacrolimus and cyclosporine, antiproliferative agents like mycophenolate, sodium and azathioprines, mTOR inhibitors like sirolimus, and steroid like prednisolone. These are the most common immunosuppressants used. Now, immunosuppressants are diabetogenic. That's where it is a problem lies. Like tacrolimus causes reversible islet cell toxicity, so that islet beta cells will reduce insulin. Glucocorticoids cause insulin resistance, and that will cause problem with higher blood sugar. And sirolimus, they impaired insulin secretion and reduce insulin signal transduction. So they are all diabetogenic. So hyperglycemia is common after transplant or any type of surgery, Now, the reason of hyperglycemia after transplant surgeries, one is stress of surgery, the use of high dose of steroids and immunosuppressants. And again, when you are in the hospital, their diets are changed, the exercise are limited in the hospital, that causes high blood sugar. And again, with the liver transplant, you do have high blood sugar. So transplant and diabetes, there will be worsening of diabetes needing intensification treatment, or they do have new onset post-transplant diabetes mellitus, PTDM, in people without diabetes. We didn't have diabetes beforehand, but they develop diabetes after transplant. So there are two scopes of transplant and diabetes talk. Now, one thing we could remember is that post-transplant diabetes is not type 2 diabetes. Although they behave like type 2 diabetes, they are coded totally different and managed also slightly different way. Now, for hyperglycemia in the post-operative period, hyperglycemia is defined as persistent high blood sugar, that's more than 11 millimole. And if it is high there, then at the post-operative period, it's better to treat with intravenous or subcut insulin. If the patient is well, we tend to manage with protamine insulin, that's isofen insulin, because quite often it's due to steroid, and the timing, the duration of steroid action and duration of protamine insulin is almost similar. So steroid is given in the morning, so we give them isofen insulin in the morning, and that controls hyperglycemia. But again, sometimes if it doesn't control, we need to add bolus fast-acting insulin before meal if needed. Now, post-transplant diabetes, it's only diagnosed after 6 weeks of transplant, not before that. And for the post-transplant hyperglycemia, we normally suggest that you measure blood sugar in the late afternoon, because in the morning, blood sugar may be normal, but because after morning you give steroid and the blood sugar may be high towards late afternoon. So anybody who is on steroid, high dose steroid, we always suggest that you should have blood sugar done in the late afternoon before evening meal. Then formal diagnosis is made of post-transplant diabetes by using oral glucose tolerance test after 6 weeks. You can also use HbA1c more than 6.5 or 48 millimole, that's after 3 months, or fasting glucose more than 7 millimole on 2 occasions. That's the ABCD and Renal Association guidelines for us in the UK. The diagnostic criteria for post-transplant diabetes is same as that of diabetes. There's random plasma glucose of more than 11.1 with symptoms, or fasting more than 7 on 2 occasions, or 2-hour plasma more than 11.1, or HbA1c at least 3 months post-transplant more than 6.5. So these are the diagnostic criteria for post-transplant diabetes. The incidence of post-transplant diabetes is roughly about 10 to 20% with kidney, 20 to 30% with heart, 20 to 40% with liver and lung transplant. The risk factor of post-transplant diabetes are mainly unrelated transplant like older age, South Asian or African Caribbean, sedentary lifestyle, obese, and there are some factors associated with transplant like glucocorticoids, use of tacrolimus, hepatitis, or post-transplant weight gain. Now, these are risk factor in Journal of Clinical Medicine said what is a very high risk factor. If you see all the risk factor, the highest risk factor is family history of diabetes, but you cannot change your family at that stage. Or old age more than 60, you cannot do anything about that. You cannot do anything about your ethnicity. The one thing which you can change is obesity. So if you reduce your weight, your risk of transplant diabetes goes down. We may be able to do something about steroid or not use of steroid, but the rest of the thing is hardly anything we can do. So obesity is one biggest factor which we need to address. Now, if we see about obesity, BMI and post-transplant diabetes after kidney transplant. See, at the time of discharge, the baseline incidence is 14.2%. But if your BMI raises by 1 unit, like from 25 to 26 or 27 to 28, the increase is plus 11, that will be roughly about 25%. Same thing after 3 months and 6 months. So there is high risk of post-transplant diabetes with any rise in BMI. So any reduction in BMI really should be tried. Now, some people try to see what is the risk for post-transplant diabetes. So they have had 7 risks. Pre-transplant is more than 50 as 1 point. Family history of type 2 diabetes, BMI more than 30, use of gout medications, hereditary use of steroid, fasting blood sugar, and fasting hypertriglyceridemia. If you use all these 7 factors as a risk, and they can say what's risk, yes or no. So if there is no risk factor at 1 year, the risk of post-transplant diabetes is about 7%. Whereas if the risk is more than 4, then almost 56%. Now that's a complex calculation they have done for an exact risk, but that's a summary of the risk. So if there is no risk factor, you have 7% of post-transplant diabetes in 1 year. If you got 4 or more risk factor, which most people have, the risk is about 56%. The treatment for post-transplant diabetes, insulin is widely used as a first line in a patient, unstable during perioperative period. That's useful because it acts very fast. You can use metformin if eGFR is more than 30 and BMI is more than 25. That's obese people with maintained eGFR. There is no data on other oral hypoglycemic. The encouraging data on SGLT2 and GLP-1. And there is no benefit on changing immunosuppressant trying to improve control. So do not change the immunosuppressant. So immunosuppressant should stay. Your most priority is to prevent rejection. You can manage diabetes somehow. There is no evidence that immunosuppressive change improve management of post-transplant diabetes. And there is no evidence that newer agents reduce risk of post-transplant diabetes. So immunosuppressive should stay to protect your organ. Oral treatment should be as in type 2 diabetes. Metformin, if renal dysfunction allows. DPP-4 of linagliptin is most useful because can be used in variety of eGFR. Glitazones, meglitinate and sulfonylurea, but they can affect the risk of hypo and weight gain is not good as we discussed. There's been encouraging data on GLP-1 and SGLT2, but in which SGLT2 there's some risk of genetic urinary infection. The treatment target, there is no evidence that tight control improves graft or patient outcome. And we try to maintain HbA1c around 7 to 7.5%, but it has to be individualized. Like if the patient is older with multiple comorbidities, there's higher risk of hypo. Therefore, higher HbA1c could be accepted in these people. Now, steroid diabetes wise, the patient who are in transplant may need fluctuating prednisolone dose during time of rejection and other thing, and that does affect the blood sugar. And there should be need for flexibility of insulin or oral medication dosing. Prednisolone also increases appetite, so it increases weight and it gets insulin resistant. Tacrolimus, as I discussed earlier, tacrolimus causes post-transplant diabetes mellitus by decreasing insulin secretion, increasing insulin resistance, and direct toxic effect on the beta cells. In addition, tacrolimus is also risk for nephrotoxicity, and like anything, they have risk of infection. Now, tacrolimus levels should be maintained between 5 to 15 as a trough level, and tacrolimus can give risk of hyperkalemia with AC and ARB. So it has to potassium has to be monitored. So tacrolimus is widely used in transplant, and whenever we treat patient on transplant, we have to worry about its level getting low or high because there's a lot of drug interaction. The tacrolimus levels are increased by amiodarone, clarithromycin, calcium channel blocker, or ranolazine, which are used in diabetes. And the levels can be decreased by carbamazepine, phenytoin, and rifampicin. So whenever you use these common types of drugs, you've got to monitor tacrolimus level closely to avoid rejection or to avoid toxicity. Now, towards the end of my talk, I'm going to talk about prognosis of post-transplant diabetes. People who have post-transplant diabetes have increased risk of cardiovascular disease and death. And it's also associated with higher rate of graft loss. But there is no data on microvascular complications. To know that, if you remember the UK PDS data, which used the newly diagnosed type 2 diabetes, they got data on microvascular disease only after 12 years. So that is why we don't have many long-term data on post-transplant diabetes. Now, again, there's always a problem with infection and diabetes after transplant. So they have to go for shielding during epidemic, like everybody who had transplant was shielded in the UK during this corona pandemic, COVID pandemic. The thing which causes more problem to us is that if they have any infection like foot ulcer, which also I deal with, they have got poor healing rate, and we have to give them prolonged antibiotics because the infection can be exacerbated, spread very fast in this thing. So we have low threshold of giving antibiotics in patients who had transplant and an immunosuppressant. Now, the other common problem is malignancy after transplant, and people who have transplant, they have to go on malignancy surveillance. Malignancy is the third most common cause of death after renal transplant. The common malignancies are skin cancer, melanoma, Kaposi sarcoma, and lymphoproliferative disorders. Now, this is the slide which shows the cause of death after transplant in non-diabetic and diabetic. If you see, in diabetic person, the cause of death is mostly due to cardiovascular disease. Also, it's non-diabetic people also. Then comes infection, then cancer. Whereas non-diabetic, the cardiovascular death and cancer is almost same, and the infection is also there. So in people with diabetes, after transplant, there is high incidence of cardiovascular death and high incidence of infection. So finally, my take-home message is insulin treatment may not be needed in type 1 diabetes after pancreas or eyelid transplant. So they may be insulin-free, but it doesn't mean that they are cured with diabetes. They need to be monitored every year or when they are symptomatic. So if they have pancreas transplant or eyelid transplant, we see them every 6 months initially or every year and give them a blood glucose monitoring kit so that they can monitor themselves. And we do annual HbA1c because some people will need insulin after that. So they become insulin independent only for few years. The other take-home message I want to give you is that post-transplant diabetes mellitus is not type 2 diabetes mellitus. It's slightly different. Post-transplant treatment, post-transplant diabetes mellitus should be treated with insulin preferably, but there are more data on SGLT2 inhibitors and GLP-1 analog could be used. And the other thing I would say is that respect tacrolimus. If you add any new treatment, monitor its level because you don't want the graph being lost. Thank you.
Thank you, Prof. Satyan. You have described in complete way all the risk assessment preparations and the co-transplants, and after that, various complications after the transplant, and the points and highlights on the post-transplant diabetes and how to manage these complications and importance of their immunosuppressant, especially tacrolimus level need to be monitored. So I will check in the chat box for the question. Firstly, to Prof. Mukhopadhyay, one of the doctors asked that the patients nowadays, the patients are staying at home and diabetes control is out of control. In that case, which insulin they should start and how they should monitor the sugar is questions asked by Dikesh Kumar. Could you ask this?
Professor Keen, and there was a noise at the background. Could you come again?
Yeah, the Dr. Kumar is asking if the blood sugar is out of control and nowadays people are staying at home, in that case, when they should start on the insulin and what insulin they should use and how to monitor and manage.
First of all, the question needs a long answer. Number two, it's not within the purview of my talk, but having said that, customarily, once the patient shows persistent fasting hyperglycemia with elevated HbA1c more than 8.5, say, we try to fix the basal first, the fasting first, with the use of a basal insulin, usually given at bedtime. And if both the fasting as well as the post-meal values are high, then a combination of short and long-acting insulin or premix insulin given twice a day, in the morning before breakfast and in the evening before dinner, do the job. And patients can be asked to have glucometers at home, and they can monitor their fasting and post-meal sugar levels and till and until they reach the fasting target, which is usually below 130. So they can increase the evening dose of insulin by 2 units, or if they're on a basal, they can increase the dose of basal. Similarly, if their target set for their postprandial glucose levels is less than 180 or 10 millimoles, so they can increase the morning dose by 2 units to achieve that. And this they can do safely at home, but then once they have trouble controlling their glucose levels with this kind of a regimen, they should get back to their doctors. Thank you. Hope that answers the question.
Sure, cover. And I want to ask you that you have highlighted that many patients are coming to us at the very late stage of their chronic kidney disease and diabetes. So what measures we should do to pick up these cases in early nephropathy?
Sorry, this is for me?
Yes, please.
Oh, okay. Yeah, but like I said before, See, universal screening for nephropathy in people with type 2 diabetes starting at diagnosis, and people with type 1 diabetes starting at least 5 years of the onset of diabetes. This is what is lacking, particularly in general practice. Unlike in dedicated diabetes or endocrine clinics, so patients routinely get checked for nephropathy at least on an annual basis. This doesn't happen. That is number one. And number two, despite the options available at the armamentarium, their implementation at the population level is a huge challenge. Reaching out to the population at risk, particularly in the rural areas, that remains a challenge which needs to be overcome. Thank you.
Sorry, I have to shoot another question by the audience. The question is that the similar situation we have to face in our country, like they are the quads, they are doing the harmful to the patients to get the nephropathy early. So any procedure or any plan to control these people or take the actions on the people?
Sorry, again, I couldn't get it.
Malpractice by the quads people, they are malpractice.
Quack.
Yeah.
Well, the place where I come from, West Bengal, we have a huge rural population, particularly near the Gangetic Delta, which is the Sundarbans, and very difficult terrain to access, and quacks have a field day there. But then, unless you can provide the people living there with qualified doctors and nurses, you cannot tell them not to go to the quacks. So there are strategies being implemented by doctors associations and nurses associations in terms of training the quacks to deliver some of the non-risky services, and also tell them when to seek help from trained nurses and physicians. So that's one of the options, which is in the state of implementation in my district, my state, West Bengal. Sorry. Thank you.
Thank you. Because of shortage of time, I will move on to the question to Professor Maharaj. So you have described elaborately about the management of the advanced stages. So what about the SGLT2 inhibitors? So we are using them, we should use in the SGLT2 inhibitor because of its benefit for the slow down the cardiorenal benefit. So what about, shall we, how early we should use without the evidence of the kidney disease like albuminuria or the slow falling of the GFR? How early we should start? Because of the cost issue there, even the RAS blockade, although we evidence-based show the benefit on protection, renal protection, there's still the under prescription of these drugs to our patients.
Thank you, Professor Keen, for the question, and I'd like to thank the questioner for the beautiful and brilliant question. Conceptually, the therapeutic intervention in diabetes should start before any changes in the kidney or cardiovascular system. So before glomerular hypertrophy or thickening of the glomerular basement membrane or mesangial hypertrophy, because the process starts with deposition and thickening and intraglomerular hypertension. So we should try to gather evidence to use these medicines as early as possible, and as Dr. Mukhopadhyay has pointed out, currently in patients with high cardiovascular risk after metformin, this has been recommended. So hopefully, this use of SGLT2 inhibitors in a high-risk patient, diabetic patient, very early in the course, just after metformin, could change the scenario, provided we can take care of the cost and compliance issue. Hope this answers the question.
Thank you. And one of the audience asks, what will be the DOC for cardiorenal syndrome patient, as empagliflozin are benefit for cardiac disease patients?
So the drug of choice for primarily like for cardiorenal syndrome, especially I believe this is for type 1 and type 2 cardiorenal syndrome, not the type 3 and for renocardiac things. So the primarily the cardiac management is the primary target. So the standard of care for management of heart failure and predominantly heart failure with reduced ejection fraction would again be use of HEI or ARBs added by a beta blocker, carvedilol, metoprolol, or bisoprolol, along with mineralocorticoid receptor antagonist. On top, if our patient is diabetic and we have to give therapy for that, yes, SGLT2 inhibitors would be a good choice, but provide the caveat is that we should take into caution that these are the patients who probably have blood pressure on the lower side. These are the patients who probably have who are using ACE inhibitor ARBs and diuretic. So the rise in creatinine or dyselectrolytemia could be an issue with the use of these things. So if we can take care of that, SGLT2 inhibitors would be good addition to the usual first-line management of heart failure with reduced ejection fraction.
Thank you. There, you have described about the pathogenesis of the diabetic nephropathy, but as noted, there are the portion of the patient without albuminuria. So are they contributing the significant percentage and the mechanism of that they having the renal damage? Could you explain about this, please?
Okay, that's again a brilliant question. Like, as has been recently recognized that not every patient with diabetes with renal dysfunction is proteinuric. Conventionally, it was thought that proteinuria is a sine qua non of diabetic nephropathy or diabetic kidney disease, but now as it appears, it's not. So almost 40 to 50% of these patients with diabetic kidney disease may not have significant proteinuria or proteinuria to start with. And the contribution could be made by like drugs, by hypertension, ischemic disease, by fibrosis, or predominant tubular interstitial, predominant involvement of the tubular interstitial compartment in the kidney to cause this non-proteinuric diabetic kidney disease. And along with like the coexistence of the other causes of like non-diabetic renal disease should also be sought for.
Yeah, these patients make it a bit difficult to detect their nephropathy earlier because they don't have any albuminuria in the urine testing. So only the monitoring that their GFR will be the only way to pick up their disease early.
Exactly. Just to add on to that, just for the same reason, the current recommendation is you don't only look for like proteinuria in urine, you also look for annual eGFR based on serum creatinine. So like sometimes we fail to look at eGFR and we miss out those chunk of patients.
Thank you. Prof. Satyan, one of the doctors asking, not the post-transplant diabetes, after the transplant, what sort of the anti-diabetic drugs will be best for these transplanted patients? So you have listed the medication. Is it for that post-transplant? I did not clear it's a post-transplant or post-transplant diabetes or transplanted patient.
Okay, for transplanted patient, you do not need to change any medication. We may have to intensify the control because with steroid control may deteriorate. So you can continue the same thing as before, but metformin, if it's kidney transplant or eGFR is low, we avoid metformin. The rest of the time, we don't change at all. But quite often, we realize that most patients needs insulin at that stage. So as a whole, you can use any diabetes as it is. You have to take into patient perspective, like it is risk of hypoglycemia, try to avoid sulfonylurea. Otherwise, you can use any of the medication.
Yeah, regarding the insulin, which insulin would you recommend? That is the doctor asked.
Well, per insulin type of view, it always depends upon what insulin, they are familiar what they can manage. Ideally, basal bolus is very good for type 1 diabetes. In the UK where I practice, most of my patients are on basal bolus regime, and quite a few of them are type 1, they'll be in insulin pump. So it's not a major problem, we carry on with that. But again, there's a lot of type 2 units. They are mostly on basal insulin or mixed insulin we carry on. And if basal insulin doesn't work, then we add mixed insulin. And if mixed insulin doesn't work, we go basal bolus regime of insulin. So it is as if any other diabetes we manage. And it all depends upon what insulin is available in different country and how costly are each regime and how much, what is the lifestyle of the patient and how frequently they can monitor.
Yeah, this is a problem in our country, like a patient have to pay out of their pocket. So in that case, analogs are not affordable, and that these renal patients found difficult.
Yeah, but in my practice, I would say any insulin is good. So you try it and you may have some restriction, right? If you go for isofen insulin twice a day or once a day, that is good. But again, there's some risk of hypo. Mixed insulin has some hypo, but you can manage. And so we have managed in our country, we have managed diabetes with zinc insulin for a long, long time, even for type 1. Once a day zinc insulin managed. I think insulin has been there for only 100 years. So we have managed different way. So as long as people are disciplined on what they eat and how much they exercise and take regular tests, any insulin will do.
If the one question is, if the patient develops hypotension or starting ACE-ARB or MRA as an antiproteinuria normotensive Dkd, what will be other options to prevent proteinuria?
Sorry, was it for me?
Yeah.
Can I have the question again?
If the patient develops hypotension or when given the ACE-ARB or MRA as an antiproteinuria agent, the patient cannot tolerate these drugs. What else they can give to protect their proteinuria, to reduce their proteinuria?
That's a tricky situation. Like the only almost every antiproteinuric agent decreases blood pressure, including the new like SGLT2 inhibitors also reduce the blood pressure. But then probably if the patient is on Western type, high protein diet, probably dietary protein restriction to the point tolerated, taking care of the nutrition status of the patient, that would be one to start with. Like keto analogs, like along with very low protein diet, like 0.3 gram per kg per day. So the caveat to this is all these keto analogs do not have established renal benefits, and also they are very costly, and there is significant risk of patient going into malnutrition. So very low blood pressure with significant proteinuria, I would say like just look at the heart, why the heart is not pumping well, because like hypertension in every advanced stage of CKD. Second is whether there is onset of other disease like amyloidosis, why the blood pressure has gone down in a patient like with nephropathy. And so I think these are the things we should look into. I don't have very satisfactory answer to it.
Difficult situation. It's a last question, although the time is late. Prof. Satyan, so what is your experience about these transplanted patients during the COVID time? How bad they are?
Well, in the UK, they were all shielded. So they were protected, and they were quite conscious of their organ and their health. So we didn't get many people who transplant had COVID and had problem. And after that, they were the first on the list to get a vaccination. And so they were okay. So in the UK, in my experience, it hasn't been that bad, but I wouldn't say that's the same case everywhere. So I would like to know from what's happening in Kolkata and Nepal. I think they might be able to ask some more help with that. So in the UK, they were safe.
Prof. Mukhopadhyay, please.
As far as Kolkata is concerned, there is no specific shielding mechanism in place. But patients scheduled for transplants and post-transplant patients are definitely advised to take extra care and not to go outdoors unless needed. And transplant programs haven't really suffered much in the government hospitals. I work in a government hospital, and my hospital offers heart, liver, and kidney transplantation. Of course, we do not have the facility for simultaneous pancreas kidney transplantation, which I got myself exposed to when I was at Manchester Royal. Doesn't take place at my hospital at this point in time. But I wanted to make this comment, and for the difference of Professor Satyan also, that in West Bengal, medical care at the government hospitals is absolutely free, and that includes transplants. So patients don't need to pay from their own pocket. Thank you.
So I think so in Nepal, as is the situation in explained by Professor Mukhopadhyay, there is no specific shielding mechanism for renal transplant recipients. They themselves secluded from public places, and that's it. And we do not have vaccination. We did not have vaccination priority for these high-risk patients. And on top, there is a public concern that because they are on so many medicines and it was so hardly transplanted kidney, there was reluctance on the part of recipients to take available vaccine also. And so currently, the anxiety of the recipients to take vaccination is decreasing. Hopefully, majority of them are vaccinated. About the effect of COVID on transplantation program in our hospital only has live related, legally related kidney transplantation program, and we had only a few successful liver transplantation. Obviously, we don't have heart or lung transplantation or pancreas and intestine transplantation. And in the early part, because of our own anxiety and because of evolving data about the COVID and transplantation and handling of the immunosuppression, we stopped this live kidney transplantation program for several months. We resumed subsequently, and with the second wave, it was again halted, but then this time we stopped for around 1.5 months, and now it has resumed in the previous schedule. And similar is the scenario with other private and government hospitals in Kathmandu. And but then still we advise them to take extra care, and especially in the preceding 2 weeks of transplantation. So we are not modifying any immunosuppression.
Thank you for your complete question. So I believe this is already late, very late. And thank you to all the speakers. We have, I think that the attendees will benefit from your very extensive talk. You have been described the management of the different stages of the diabetic kidney disease until the kidney transplant, and even the advanced management in the UK, including the pancreatic transplant. So it will be very beneficial for the attendees. Thank you for staying late with us. And all the speakers, thank you. And the USB for the supporting generosity of that they are supporting our educational activity. And thank you to the Nepal this association for inviting me to chair these sessions. So thank you. So good evening, everyone.